favorite verses is, our people perish for lack of knowledge. So Kim is here today to drop some knowledge, drop some nuggets that's going to help us as we go through this myeloma journey when it comes to talking with our doctors and our care team. So without further ado, Kim, I'm going to turn it over to you. The floor is yours.
Thank you, Valerie. Thank you. Thank you. Great to see you again. Good afternoon, everybody. Thank you for your time today and agreeing to listen to me for a few minutes. As she said, Kim Burney here, oncology clinical educator at J&J, oncology nurse for 37 years. Since I graduated college, I have to count it up sometimes because it's flown by. But when I see the advancements in medicine, specifically multiple myeloma, then I'm just excited to have been then taking care of patients and then now on the cutting edge of the treatment landscape. And so I'm going to share my screen, and if you all will let me know when you're able to see it, I would appreciate that. I'm going to come off camera while I present. Can you all see my screen? Can you all hear me?
Yes, we can see it and we can hear you.
Okay, perfect. Perfect. Thank you. Thank you. Thank you. I want to get it in. Yeah, here we go. So we're going to be talking about shared decision making. So when you're dealing with any kind of issue in life, whatever you're doing, you want to be sharing in the making of the decision. If you're having flooring installed, which I will be doing in a few weeks here at my house, I want to be a part of the decision, right? I want to be able to choose which floors go down, and I want to make an informed decision, meaning I want to not only look at the color, I will need to look at the durability and all these other things. So when it comes to medicine, we also should be making decisions in a shared space with our team. And as I've been a nurse this long, I've found that that does not always happen. And so at J&J, we want to make sure that we can bring value more than just talking about the treatments, which we know are working for our patients out there. We want to make sure we can come and also give you some tidbits to help in your shared decision making, helping you to make decisions regarding your care. And that, again, that starts with education. As Valerie said, I love saying that, our people perish for lack of knowledge, and that is definitely true. And so today, let me give you a few program disclosures. I did not develop this slide presentation. Janssen did. Of course, Janssen used to be a part of Johnson and Johnson, and then it went away. And now it's just Johnson and Johnson Innovative Medicine. I am an oncology educator and I'm presenting this information. So let's talk about what are we hoping to learn today. Number one, I want you all at the end of this presentation to understand what is the shared decision making. What is it, right? How are people empowered, or I want you to feel empowered to have discussions with your healthcare team and then learn how to apply the share approach to engage in these discussions, because there is not, we didn't just come up with share. There's an acronym that has been investigated, researched, that the American Association of Nurse Navigators has come up with. So there's actually a share model, and there is an acronym for share that stands for share, help, assess, reach, and evaluate. And so we already know about myeloma, and everything J&J puts out on the myeloma platform starts out with talking about the disease. We already know it is a hematologic disorder. It involves malignant plasma cells, and they grow out of control, and then they crowd out the bone marrow and cause other issues in the body. And the complexity of myeloma, especially now when we look at the treatment landscape, makes it a perfect disease state example for this presentation. You can apply what I'm saying to any disease. However, because it was developed by Johnson and Johnson through the myeloma team, you're going to see myeloma all over the screen, but I can go out into a prostate group and present this information because it doesn't really change. I hope that makes sense to you. And so myeloma, again, is very complex now, and there are many, many treatment options, and you should be able to get the information, process it, ask your questions, and figure out what's the best route for you to go. So we already know there's over 30,000 new cases a year, and about 150,000 people. And this data is old too, from 2018. We're living with myeloma in the United States. The 5-year survival has improved. Now, the latest data, this 55.6% is over 61%. So again, the 5-year has improved drastically over the years. Even my 37 years, I've seen such a great amount of growth. And so what does shared decision making do? Basically, and what is it? Let's back up. What is shared decision making? It involves making treatment decisions through collaboration with your healthcare team and whoever your caregiver or caregivers are. It is not you sitting down and a doctor telling you this is what I want you to have and you just running with it unless that is your choice, right? Unless that is your choice. It is a very important component of patient-centered care. That is what the goal should be, care that in which the patient is at the center, and then it has an impact, positive impact to the quality metrics. Why do we care about that? Because now prescribers reimbursement is often tied to satisfaction scores by patients. And so if you're talking to your patients, acknowledging them, listening to them, and involving them, then they feel better about their healthcare team and they rate the facility or even the prescribers and providers higher. And so if the quality metrics are higher, then the reimbursement from these healthcare companies and these managed care companies tends to be better. And so myeloma patients can have different preferences as they go through lines of therapy. Right now, we know there's nothing that we have said that cures myeloma. And so we expect it to be a system or a trajectory or a continuum of diagnosis, treatment, remission, diagnosis, well, relapse, and then treatment remission, and so on and so forth. And so patients and providers can consider trade-offs. What are trade-offs? Balancing the risks and the benefits in making decisions. Every treatment has some risk in terms or side effects. So you need to have a good understanding. This regimen has these side effects. This regimen has these side effects. And make sure that you're getting adequate information. Then also, patients wants to work that has the most efficacy early in their treatment journey. They want the one that's working the best, that's giving them the best response. But these are not static because sometimes the medicines that have the best response in the clinical trials, your body say no, it doesn't like it, and you have to switch. And so none of this is written in stone. The preferences have to evolve over time throughout the patient's journey and throughout their treatment. So it is a collaborative process. That is the key word. You're going to hear a lot of talking about collaboration, not only just between the provider or the prescriber's healthcare team and the patient and the caregiver, but the patient and the caregiver. The patient and their family should also be coming together in an ideal situation to discuss what the options are. So, what does the shared decision making entail? Number one, a conversation between at least two participants, a healthcare professional and the patient or the patient's caregiver. At least two people, okay? All parties do what? Share key information. Your prescriber should be sharing clinical evidence, right? He or she should be saying the latest data shows that if you have this and this and this as a part of your myeloma, that this regimen works best. I also have other options that I can show you. Da 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 da. They need to be able to provide information so that you can make an informed decision. All parties should actively engage. And so you need to take steps. It says here to build consensus. I'm going to step back and say build relationship. Build relationship. That is the foundation of everything. Because if you build relationship with your healthcare team and your healthcare team is seeking to build relationship with you, then that makes communication, collaboration, and all that a lot easier. And number four, it is a mutual agreement on the treatment plan. Now, there are some patients who don't want to go through all this. They say whatever the doctor says, I'm going to do, I'm going to go with that. And that is perfectly fine if they make that decision to do that. But we should be offering them a chance to participate in their decisions. And so, what are some of the goals? Number one, there's some immediate benefits. Patients have increased confidence and understanding of their treatment and the decisions they made. And then there can be less stress on the patient and the caregiver. There's a longer term benefit, better quality of life for the patient. Why? Because we have chosen the regimen that the patient feels most aligns with their life and what their goals are, but also has efficacy to take care of the malignancy. There's higher satisfaction with treatment decisions, and this to me is the biggest one: enhanced trust in your healthcare team. If you do not trust your healthcare team, that is a hard place to be because you're literally coming in there and putting your life in other people's hands. And when you're doing that, you need to be able to trust them. For me, when I was working in the clinic and taking care of oncology patients, that was my first goal. I wanted them to trust me. I wanted to build relationship with them because I needed them to be able to come to me and talk to me about things that they may not even have been able to talk to the prescribers about. They spend more time with the nurses or the nurse practitioners. And so that is usually where the big and lasting relationships can form. You can have a relationship with your physician. I'm not at all telling you not to. My point is seek a relationship with your whole team. And then what are, again, outcomes of this shared decision making? Improved outcomes and avoidance of decisional regrets. Decisional regrets. I have a story I can tell you all about a friend of mine who was diagnosed with breast cancer years ago. And I was working in a clinic at the time. And when she told me, I had her come to my clinic. Number one, I felt that the oncologist was one of the best in the city at taking care of breast cancer. And then I would be there as well. And she chose the less efficacious or the treatment regimen that was that was recommended second because it would not take her hair out. It was not the best regimen for her, but that was utmost importance to her. She got the second best regimen and she didn't have good outcomes. And she did verbalize to me how much she regretted not taking the one that I tried to talk to her as her nurse. I tried to talk to her as her friend to tell her, yeah, your hair is going to come out, but this is the heavy hitter for this type of cancer. You really need this. She would not do it. She ended up passing away. And but what, as her nurse, what did I have to do? Accept her decision and continue to care for her as the nurse. No matter how I disagree with her decision, I had to stop putting my stuff in it and go with what she decided. So we do want to avoid decisional regrets. And so let's talk about the survey. They did a survey. It was only 20 patients. But when they surveyed these people, 19 expressed to have a preference or an active role in their shared decision making. However, in a lot of practices, it is not fully implemented. And as I said, you're going to have a few patients, especially nowadays, that don't want to be active in their care. When I was a young nurse 37 years ago, that was the norm. Whatever the doctor said, patients would go with it. But when the internet came about, people started having information at their fingertips and they can pull stuff up. And so they started coming in with pages and pages of things they had printed offline, bringing it in to discuss it as a part of their treatment regimen. And so I literally watched the evolution of patients taking a more active role in their treatment decisions. Are there challenges? Yes, there can be patient barriers. There can be practice barriers and then other ones. In the practice, who can identify with takes too long? Takes too long. I worked for a doctor once who would only allow 30 minutes for his new patients. And I've only worked in oncology. I've never worked outside of cancer patients. If you have a new patient, 30 minutes is not usually enough time to go through all of their stuff. But that was the time he gave, right? The multidisciplinary team needs to be coordinated. What does that mean? That means depending on your diagnosis, you need the oncologist, you need the radiation doctor, you need the nurse that'll be administering the chemo, you need the nurse practitioner, you need the the radiology person that will be doing your scans, you need the surgeon. All of these people need to be involved in your care. And so trying to coordinate that can be difficult. The clinicians may need training. That is where I come in. If you're ordered one of a J&J myeloma drug, I am the person that comes in my territory and makes sure the nurses are up to speed, the pharmacists, the nurse practitioners, and sometimes the doctors. That is my role. And then sometimes there are hospital protocols and insurance companies that prefer certain regimens. I've seen that a lot. I have battled a lot with insurance companies over my career. So what are some of the patient barriers? Patients are hesitant to speak up. They see the physician as a person of power. And that is true. And they feel that if they speak up, then they will be making the person mad or having them feel a certain kind of way. I don't know how many times I had patients leave the clinic and call me back and say what they wanted to say to the doctor, and then I have to go and kind of be the mediator. And I would go in and say, Miss So and so called. She know y'all talked about this, but these are her concerns. Would you call her back? And I had to do that a lot of times. A lot of patients do what? Feel overwhelmed and are unclear. That is why I urge everybody to take somebody with you that can sit and even take notes, because your ability to absorb that information when you're dealing with that type of diagnosis is compromised. Language or cultural issues. Language. Now we have all kinds of languages, people that speak different dialects and languages in this country. And so if you don't have a medical interpreter, if there's a person that does not speak English and it's an English speaking facility, that can be really challenging. You should not have your family member be your translator if you are dealing with medical stuff and you don't speak English as your first language and you need Spanish or Chinese or what have you. You need an interpreter trained in medical terminology because your relative's ability to translate the meaning could be compromised. And then the differences in goals, right? Sometimes the caregivers, and I've seen this, want patients to keep taking treatment and keep taking treatment, and patients are coming behind them saying, I'm tired. I don't want any more treatment. I'm just ready to let whatever happen happen. I've had to intervene with that several times too because they didn't want their loved ones or their caregiver to think they were giving up. But people have been treated for years and were just tired of going through it. And so you may have to make sure that everybody is aligned on the same goals. And then the time restraints or other barriers, organizational practices, and then resource limitations. This medications, these treatments are expensive, so it also depends on the insurance company, your ability to pay certain things, resource limitations. There's a thing called financial toxicity when you are dealing with these treatments because now they are doing quad therapies, which is four therapies, or triplet therapies, and the cost can definitely mount when you're dealing with that many treatments. And so a collaborative approach can help address some of the barriers, right? You got your healthcare team. They have you should see someone who has expertise in treating myeloma. You need to see an expert. I'm not telling anybody, and I recommend this for anybody. I'm not telling anyone not to go to their community oncologist, but your community oncologist may treat breast cancer, lung cancer, myeloma, melanoma, leukemia. They may treat all these things. I'm just suggesting and advising that you see a person who specializes in myeloma, get their input. Most prescribers are not going to be upset if you seek a second opinion from an expert. Why do I recommend that? Number one, and I use this analogy, if I have that Mercedes S550, which I would love to have, and something's wrong with it, I'm not going to take it over to Firestone that can work on the Toyota, it can work on the Ford, it can work on, I'm going back now to Pontiac, for anybody that remember that. I want to take it to a Mercedes dealer that all they do all day is every day is Mercedes. If I'm getting a diagnosis, whatever it is, it doesn't have to be myeloma. I need an expert opinion to weigh in. A lot of times, the expert may be a distance away. So you can have the expert weigh in and then go to your community doctor and get the treatment. That is definitely what I recommend. Make sure that the therapeutic options have been optimized and that they're giving you your stuff based on evidence, right? There are treatment guidelines that are out there that say if a person comes to you and have this at this stage and it has this is what you should give first, second, third, and so on. Cultural differences is huge. Huge. We have to understand the individual and different cultures and their experiences, and okay, and how to navigate that. And then an understanding for the differences, right? Can I understand that this person who has this belief is over here and needs treatment, but this person over here has this belief and needs treatment? I, as a healthcare professional, and I like to tie things back into myself, had to do some quick reading and say, okay, with these over here, as a woman, I cannot touch this male patient right here. There are some that, as a nurse, I would have to have a male come in to do certain things. Well, over here, this group over here, when somebody passes away, they beat themselves and wail. And so you have to be able to allow people to practice and keep their cultural identity. Patient and caregiver preferences. What are their financial concerns? Lifestyle commitments. How many of us now have grandchildren? And my grandchild has to get off the bus every day at 3 o'clock, and I need to be home because my daughter works. So I can't have a chemo that is 8 hours long. I need a different option. Okay. What are the learning styles, right? Does this person learn better by hearing it? Does this person need to write everything down, or can I give this person brochures and they go home and read it and then come back to me? You have to figure that out. And then health literacy is huge, right? There's literacy and then there's health literacy. Because just because a person is literate does not make them literate in terms of health and medications and terminology. An attorney is not usually health literate. Does that make sense? So we have to make sure that people are understanding. And then transportation can be an issue, housing can be an issue. And then also, when you start talking about patient issues, mental health has become a huge issue now, right? And then goals. Shared decision making, a mutually agreed on treatment plan, which improves outcomes and maintains quality of life for the patient as best as you can. So if you look at this circle, this diagram in the middle of the page, that decision is sitting in the middle of overlapping through all of these different things. That is what they would call the sweet spot that we hope to get to. So let's look at the decisions, how they are made, a complex environment, right? If you have myeloma, you have one of all of these usually. That's not counting the radiation doctor that you may need because you got a little fracture in your back, right? That's not counting the pulmonologist because you came in with a history of COPD. That's not counting the social worker who is working with you because if you don't do this at the end of the month, you're not going to have a place to live, right? So it is a complex environment, and that is why, as patients, I'm going to urge you all to go to your healthcare team if you have concerns, because a lot of times there are resources that can help you out. And so roles and responsibilities vary by institution and practice, right? Multidisciplinary team coordination and patient advocacy go hand in hand. You see what's in the middle of that? That's a nurse, right? That is the symbol for nurse. They wouldn't have the doctor sitting there like that. He would have a stethoscope around his or her neck. But you want to make sure that, they consult on patient visits. This is what the navigators and the oncology nurses do. Educate, assess the health literacy, monitor labs, patient results, answer phone calls, speak at different things, and then identify barriers and issues and try to find solutions. A lot of times it's the nurse that digs through and can come up with solutions for patients. And I'm not saying that because I'm a nurse. I'm saying it because I'm a nurse. I'm just kidding. So SHARE again is a framework. It's developed by the Agency for Healthcare Research and Quality, and it has a five-step process. SHARE helps to gauge patient preferences, standards, and goals. For what does it deliver? The SHARE model, the last one, a trusting and lasting relationship between the healthcare professional and their patient. Improved adherence, right? The patients can stay on medicine or adhere to their regimen better when they have had a part in making the decision, and then improve quality of care and overall improve satisfaction. So let's talk about the S. S, you want to, as a caregiver, I'm going to seek the patient and the caregiver participation. Most of the time, that will start before the physician even sees them. I'm going in and I'm saying, "Hi, Miss So and so. I'm Kim. I'm Dr. So and so's nurse. Da 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 da. Tell me a little about yourself and your situation. Da 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 da." And then that's when I gauge how involved do they want to be in the decision. Then the healthcare team helps patients explore treatment options, assess their values and preferences, right? Their values and preferences, huge. Research a decision, which a provider usually has that already. But I want to urge patients to take the options and think them through and weigh their options with information, right? You've been given information on this is how it's given. This is how many times you have to come. These are the side effects we're going to look for. This is how we know whether it's working or not, right? And then you're going to evaluate that decision. So invite involvement. This is what I would do as a nurse. Invite involvement, summarize the decision, right? A lot of times a physician would go over it, a treatment plan would be decided upon, but then I would need to go in, make sure the patient had the prescriptions, make sure they had their other appointments, and then say, now this is the treatment regimen you will be getting, and this is what you can expect. Make sure you openly communicate the potential risks and benefits. Doctors should definitely do that. A lot of times the doctors go through options and tell you this is the regimen, but when you get down, I call it to the nitty gritty. A lot of times that's a nurse practitioner or PA or a nurse that tells you this is your regimen and this is what you can expect from your chemo. Assess the role your patients want to say and can then consider any barriers, beliefs, and preferences. Help them understand it's a complex treatment option. Most of the time, myeloma patients now are on 3 to 4 medications at the same time. So make sure that patients understand their treatment plan and then invite the patients to be engaged, right? Identify that new health conditions can occur and that anything that pops up within the course of your treatment, you need to make sure you let the doctor know. Don't decide for yourself whether it is significant or not. Let us decide. I used to tell the patients, you tell me anything that's different and let me decide what we need to do about it. Clearly explain any uncertainties and limitations, right? Make sure we're not trying to say, ooh, this drug works wonderful. The overall response rate in this trial was 93%, but I don't tell you, but it can cause nausea and vomiting and diarrhea, right? That is imbalance. And then make sure that we're giving things that can be taken home, because once patients get usually a first treatment, they can calm down. I used to get most of my questions after they got their first treatment, because by then they knew what to do, what to expect. They had gotten it in, and now they could think, right? Assess the decisions. Make sure the patient's priorities are up front, right? Find out what matters most to the patient, right? Encourage ongoing conversations. Listen. Open-ended questions, right? You don't want to ask Mr. Smith, Mr. Smith, are you numb? Having numbness in your feet? I would usually say, Mrs. Smith, have you had to help Mr. Smith button his shirt lately? And then I would get more information. Then make sure we're empathetic. That's huge. Acknowledge your interests and preferences, and make sure as a patient you speak up for that, and then help prioritize. Let's put this thing into a priority list, because some things are not priority today, but they may be priority as you go further into your journey. Reach a decision, right? It is collaborative. If you need more information or more time, say that. Just because the doctor has you come in, you get this, and they want to start you on next Wednesday, you may need to delay it for a Wednesday to get your family together to talk it through and make sure that you are all aligned on your decision, and then confirm what that decision is. Then you're going to evaluate it, right? You're going to evaluate the response. Is this treatment working as it goes along? Do we need to lower your dose? Doctor, I know you think this is working, but I am so numb that my fingertips are aching. May have to reduce the dose. Barriers like logistics and travel. Well, you know what, Mr. Smith, we can give this to you in a pill so you don't have to try to come here but once every 3 weeks instead of coming every week if you get it through the vein. These are just examples I'm throwing out. And then always be ready to revisit the decision and consider other options, because sometimes it does not just go straight forward. So there are a lot of resources here on the screen that can help guide, right? There's the AON, I talked about that up front, the Academy of Oncology Nurse and Patient Navigators, ASCO, which they'll be having that soon. I mean, ASHES soon, I'm sorry. The International Myeloma Foundation, MMRF, Leukemia and Lymphoma Society. And then there is a checklist that certain um, practices have to help with the decision making. Is this person newly diagnosed? Have they relapsed? What did they present with? What is their learning style? What is this or that, or other current medications? And so we do have some patient um, case studies here. Just, I'm not going to go through those just verbatim here. It's just showing, certain things about these patients as they went through the share model here, um, and helping to uncover these things. And so share their notes, right? We when we did the share model in my practice, we made notes of what the person preferred. And so that is what I want you to take away here. Your healthcare team should have notes that say, this person learns better with this. He has a transportation challenge. He lives alone, does not really have a caregiver. So we need to make sure somebody is calling him on day 2 and 3 to check on him, so on and so forth. And then here's another one with Angela, who is a relapsed refractory patient. Same thing. There is uh, the share model, I'm sorry, was applied for her as well. What are her concerns? All of these different things, and help her decision. And what did we uncover about Angela? That she wants to maintain her active lifestyle. She has been diagnosed before, so she has a better understanding than a newly diagnosed person of the disease itself. And then now her husband is no longer able to be her primary caregiver. Now her children have to come in and take over. And so again, shared decision making and myeloma care is very important. myeloma care is a continuum now, and it involves multiple shared decision-making opportunities. It's not that you start with this opportunity at the beginning or when you're newly diagnosed and that's the only time you do it. You have to be understanding that all decisions are fluid. They may have to change. May have to be revamped. Patients' preferences vary by line of therapy. The oncology nurse, the navigator, and the APPs, which are your nurse practitioners and your physician's assistants, are crucial and critical in identifying patient preferences, as well as a whole lot of other things in taking care of patients. And then the share model is a useful tool, a very useful tool. Other resources right here: Share Approach. These are websites: the Health Well Foundation, Cancer Care, A Helping Hand, the Patient Access Foundation, Multiple Myeloma. Again, we talked about the MMRF and the IMF earlier. So these are just resources that you can go to. When I said now patients can come and print out a whole book on what they saw online, that's where you can find reliable information. And you should make sure you're not just going to Wikipedia trying to find information. You want to go to a reputable source when you're trying to find your information. Other ones for nurses: Oncology Nursing Society, so on and so forth. That is all I have. Are there any questions? Can I answer any questions for anybody?
All right. Thank you, Kim. So if you do have a question, raise your hand, drop it in the chat box. If you can't find the chat box, just wave at me. I kind of acknowledge you there. Um, awesome presentation, Kim. I do have some questions that
Okay.
people had sent in prior to this, and one of them you touched bases on a little bit, but how can patients make sure that their spiritual beliefs, cultural values, and personal priorities are included in treatment decisions without feeling dismissed or misunderstood?
That is a great question. The first thing is to make sure somebody understands what your cultural beliefs are, because a lot of people may not understand what it is, right? I've had patients where I ask certain questions and they say, I will not accept this and this and this because of my religion. And I make sure that it's in there and it's displayed and that everybody knows it. And usually, if you're upfront about it, most healthcare providers and teams go with what you say because we want to treat this over here, but we can't dictate the rest of your whole life and make you do or things that propose things that are against what your religion is or what your cultural preference is. And so, if you are finding that you have an issue like that and your providers you're feeling dismissed or whatever, go find somebody else,
Yeah.
because you should have a great relationship and trust in your healthcare team. You don't go to the grocery store that don't treat you right. Why are we going to providers that don't treat us right? There are too many out there to stick with somebody. And I used to always tell new nurses when I was training them, do not ever walk to a chair and act like you don't know what you're doing, because the patients know it, because they need to be able to trust. So I don't want to be in the chair and you putting something in my vein and I'm side eyeing you, right? That is a bad feeling. So go to somebody else, seek another opinion. That as a nurse this long, that is my
Yeah.
advice.
Okay. And just to piggyback on that, Kim, so, and this is part of the other question that was sent in. What happens when a patient and their doctor strongly disagree on a treatment plan? How do you navigate that disagreement and still maintain a respectful relationship? Because we want to just up and pack our bags and go and find somebody else, but sometimes that's not always an option when it comes to different insurances and stuff like that. So
That's
how
true.
do we still maintain the respect in that relationship and, still get the treatment, that's going to keep us alive?
Well, you want to make sure that what you're choosing is best. That's number one. Now, best does not necessarily mean best from the doctor's standpoint, best from yours. And then if you respectfully say, I hear what you're saying. I know this is what you're recommending, but I also would like this part right here because this fits me better. I've had hundreds of patients to do that, and it has not been an issue. But again, every doctor doesn't have the ego that will allow for that,
Yeah.
and you have to walk a walk with it. You have to make sure, just as you want them to respect you, you're respectful. You're not argumentative off the jump unless you need to be, but that you're saying it with respect, with all due respect. I know this, but I want this right here. That's what my friend did when we tried to get her to get that other regimen. She heard us clearly, but she still decided she wanted that other regimen. It was out of my hands then, and I couldn't hold it against her. I had to take care of her, and my team had to take care of her, even though we didn't agree with her decision. So it's a tightrope. You walk it, you speak clearly, you make sure you're heard, you make sure they're taking time to hear you and express your concerns. And even if you need to leave that day and set up another appointment and come back to talk, please do it so that you're most comfortable with whatever is going on.
Awesome. And I think it's just learning how to really advocate for yourself is what it kind of boils down to.
It definitely does. And that's where getting in with your nurse can do, or your not, your nurse practitioner or your PA. We do most of the advocating when it comes to certain things because I had one patient who she wasn't going to do nothing if her husband didn't say it was okay.
Mhm.
Doctor kept trying to talk to her. Husband sitting there. I'm sitting there watching. And so when I went to him afterwards and I said, when you go back in, can you address him? He said, why is she the patient? I said, because she's not going to do anything if he don't say. And I had to say that, and he went back in and started talking to him and saying, "Is that okay with y'all?" And boom, it worked out perfectly. But I was able to see this lady ain't hearing nothing you saying because her husband felt left out, and he was the head of the household
Yeah.
in her head, right?
And I think that goes back to just knowing the culturals and understanding, that everything's
Yes.
different
The
there.
age when they were brought up, all of these different things play a role in taking care of somebody.
Yeah. Yeah. Um, so this was a question. The gentleman was asking this questions. How should patients prepare for situations where their personal wishes about treatment might conflict with what the care teams believes is safest and what they can put in place now so their care team is ready to kind of guide those decisions if that moment ever comes. So, they're in a good place now and they're making good decisions, sound
Hmm.
decisions, but if it comes to, later to where they don't have that opportunity, what can they do now to kind of make some plans and
First of all, have a caregiver or somebody that knows your wishes and what you want, right? They call that, I think, a power of attorney for health care.
Mhm.
That is huge if you get to a point that you are unable to care for yourself or in terms of making your decisions. I hope I'm going the right way with the way the question was asked.
Yeah.
That is number one. Number two is making sure that you are informed, making sure that you're not wanting this line of this treatment just because Mr. Smith got it and he did well. Mr. Smith's disease might be different than yours. Make sure that what you're getting is tailored for you and the way your disease acts. All myeloma is not the same. When I was a young nurse, we could line three newly diagnosed myeloma patients up and they all got the same thing.
Mhm.
Now you can line three myeloma patients up and they look at the way their particular disease acts and they put them on different things. They can get three different things because we have more research and more knowledge now. So I would say make sure that your wishes are clearly communicated, however they need to be, whether it needs to be in writing, whether you need to have a caregiver or an advocate. They even have patient advocates out there that can express your wishes if you just get to a point that you really can't. And if it was the question that they wanted something that the docs thought was more toxic than they could handle, I thought I heard something like that in there.
Yeah.
And that is tough right there because the doctors are not going to want to face liability if they feel clinically that you can't handle a treatment. That
Mhm.
is very tough. That's a tough place. I've been in that place before, and doctors have just refused to give it
Mhm.
because they felt that, but they explained it to the patient. If I give you this, and the liability was too great. So I hope I answered that question to the
Yeah.
person's satisfaction.
Yeah, I think that's a good idea. And we don't often talk about those power of attorneys and getting all that paperwork because we never think that we would get to that point. Oh, that'll never
Hmm.
happen. Or
Hmm.
my family, they know what I want and they can be
Right,
respectful. And
right.
that's not always the case.
Not at all.
Awesome. Thanks for that. Just wanted to see if we had any questions. Did anybody have questions? I got a couple more that I can go through but I want to make sure that if somebody has questions, they raise your hand or just come on camera, unmute your microphone. I'll know that you're looking to ask a question there. And you touched a little bit on this as well, Kim. So
Hmm.
what role should family and caregivers play in shared decision making, especially when the patient wants support but doesn't want to feel overpowered? Like this is, I can make this decision, but I want you to have some kind of say in it. So, what can they do in those, or what role can the caregiver or family members, not necessarily a caregiver, play in those?
So what I used to do in that situation is not force the decision right then. Okay. The caregiver felt a certain way. Patient was not like, just overwhelmed. Let's give this a few days, right? Also made sure that there was a understanding of the options. Option A is this, and sometimes you have to put it down. Option B is this. These are the pros, these are the cons. The doctor is favoring option whatever, da 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 da. But you also can have this one because this is this and this is this. So I found that taking a little more time, giving the person a chance to calm down, the patient. When I say calm down, I don't mean they were in there just ranting and raving, but the anxiety level and the ability to absorb and even the ability to participate in that at that time in the decision was just not there.
Mhm.
So I always believed, and so I always tell people, unless they tell you you got to go to the hospital right now and start something, then give it a few days, absorb it, talk it over, communicate with your caregiver, making sure that, and then if you are the caregiver, communicate with your loved one, your person you're caring for. Allow them to say what they want and then be willing to abide by what they want, even if it ain't what you agree with. That's the big part, okay? But communication and time, I think, is big in those types of situations.
So we think about shared decision making and a lot of times in multiple myeloma, the patients aren't always offered transplants, and they refer to them as the three T's, the CAR T and um, the triplets there.
Mm-hmm.
So if a patient feels that they are not being offered the same treatment options as other patients, um, how can they address that directly and make sure that they're getting like equal access to care? What comes to mind a lot of times is the CAR T, and maybe somebody's treated at a community center, and things of that nature. Specifically now that they are coming out as well.
That is why I say go to a myeloma specialist, right? I know a lot of times it may not be, you may not be able to get to one. Make a phone call, see if a myeloma specialist can even do a video chat with you because if that's possible, because they can have your records and give you the recommendations without looking at you. because the most of the myeloma specialists are on the cutting edge of everything new and new guidelines, new trends, all of this. The medical oncologists, if they're not following up on it, and a lot of them don't, why? Because they got to follow up on the breast cancer, the lung cancer, the colon cancer, the myeloma, all these other things. And so again, seeking another opinion. And if you feel you're not being offered the best care, please, if you can, go to somebody else. Go to somebody else, because that's one of the reasons why we have some disparities in myeloma, because certain people are not offered certain drugs. I met a young lady last year. Her father had passed away from myeloma, and I'm not trying to be biased because that's our drug, but never received Darzalex. And daratumumab is really a staple right now, or anything in that class. I can't answer why at that time that he wasn't offered it, other than they lived in South Georgia in a really small town, and I have my thoughts on it, but that type of thing. And so I urge everybody, please, please, please try to see a specialist. Get the information and then go to your doctor with it. Say, oh, I went to a support group. That's another thing. A myeloma support group is a wealth of information, because other patients are talking about what they've had, who they see. Oh, Dr. So and so is wonderful, and da 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 da. Patient support groups. A lot of times we shy away because we don't understand that the support groups are not sitting in there going, woe is me. That you're sharing and you're celebrating each other's successes, and you're sharing information, and you're on the cutting edge. The support group people know more than I do a lot of times, because they're out here looking at what's being approved and when.
Yeah, thank you. Thank you for that. Mary, can you go ahead and unmute and ask your question?
Hi, I didn't
Hi.
really have a question. Hi. It's been about a month. I'm smoldering.
Oh,
And
okay.
before I heard those words, I had no clue as to what was going on. I just
Okay.
wanted to speak to the overwhelm that I felt leaving the doctor's office, because the recommendation that I got, and nothing against anybody, but the recommendation I got was stay hydrated. And thankfully, I found HealthTree and was, because again, I'm still kind of in a state of overwhelm, but I
Yeah.
found
Yeah.
different things on the platform like this. I just went to something earlier in the week about 10-year survivors. So, and then going to a specialist, because my mind wasn't even there. I was thinking
Right.
that
Right.
my healthcare provider, that company, would carry me through this,
Right.
but didn't even think about it. And I got resources in my area that I could go to. So I just, more than a question, want to thank you all for doing things like this, because again, the overwhelm is real.
Good.
And I'm just
Good.
really, really thankful for that. Just thank you.
You're very, very, very welcome. Can somebody talk about smoldering? Yes. So, so smoldering is believed to be a precursor to active myeloma. That means that your blood is showing some abnormalities, but you may not have all of the criteria. Every box is not checked to say you have full-blown myeloma. The belief, though, is that as you live with smoldering, at some point it's going to convert to full-blown myeloma. So it's kind of smoldering, like if you like they kind of use it like a fire. It's still hot. It's just not a flame yet, if that makes sense, right? But the belief in, and there's research that shows that eventually it moves to smoldering, and now there's new treatment now for smoldering. Smoldering used to be a watch and wait. They wanted to check your blood every so often and then wait for you to convert to myeloma. But the researchers said, why are we waiting? Why don't we go here and try to hit it over here? And there's recently, as in last week, a new treatment. It's an old treatment, but it got an approval for myeloma.
And that's basically what they said. I'll see you in a couple of months and let's see what happens. And again, I'm walking out like, holy smokes, what just
Yeah,
happened?
yeah.
But that
And
again, that's why I appreciate this platform.
yeah, so that was the treatment, quote unquote, observation, checking. And, I had a lot of patients that were even in the monoclonal gammopathy of MGUS stage. MGUS is even before smoldering. That we checked first every 2 months, then every three, every six, once a year because their numbers weren't moving. And I don't even know what happened to them, but they never converted to myeloma while they were at my clinic.
Well, I
They
was in MGUS and didn't even understand that. No talk about smoldering and what this could become was talked about
okay,
before. So it's just wild. And I'm just glad to be able to have information to make
good,
choices.
good. Have you seen a myeloma specialist?
No, because again, this is very new. I'm gonna connect the records and everything so I can do that. Like I said, they made suggestions to me for places in my area. And just again, being on the platform and listening to
Yes,
different things, it helped
yes.
me realize that is my best way to go. And that's why I'm
Awesome,
thankful.
awesome, awesome. Please seek a myeloma specialist because they are no longer, most places are not just sitting and watching it anymore. There was a treatment approved last week for smoldering.
Yeah, absolutely. We'd be happy to get you squared away, Mary, with that as well. And awesome.
Miss
Thank you.
Brenda White Phillips has her hand up.
Yes, I was going to say something. Then you said it about, I read recently that there's been some second thought on how to treat smoldering. I was diagnosed with smoldering in 2011.
Okay.
And, and at the time, the doctor was saying, my numbers were kind of right. I guess they look at certain things and say before you
Yes,
need treatment.
yes.
I was right at that cusp of needing treatment. So the thing was, we'll watch and see. So every 3 months, I had to go in, and my numbers sometimes would get better, but then they just never reached treatment stage. But I was blessed that I went 11 years. I smoldered for 11 years before
Wow.
I had to go into treatment. But
Wow.
like I said, I read recently that now they're even thinking about, treating you as you're smoldering.
Oh
But
yeah,
uh,
it's a
the
reality
research,
now, Miss Brenda.
I'm amazed at the research in multiple myeloma because I had a good friend diagnosed in '04, and at that time they were trying to find a stem cell transplant donor,
Uh-huh.
and he was in the hospital for like over 3 weeks. And then when I finally went into treatment and I had to have my stem cell, I was an outpatient for 19 days. So advances have really, really evolved. So for those of you who are just starting out, be optimistic, be faithful, because and follow everything Kim was saying about communication and
Yes.
being up to date and staying with HealthTree and joining maybe even another support group.
Yeah.
Thank you, Miss Brenda White. Appreciate that. I can remember when I was a young nurse, and I'm going to be really frank here, people. Myeloma patients were usually dead in a year or two because by the time they got diagnosed, it was far advanced. Now, when I hear people living 30 years on treatment, but living 30 years, I'm just ecstatic to see where we are.
Yeah. Yes. Oh my goodness. Wow. Well, thank you, Brenda, for sharing. We
Oh, let
are.
me let me clear up something. For the smoldering, it has to be high risk smoldering that gets the treatment. If it's just standard or low risk smoldering, they're not treating that yet. So let me clear that up. The treatment that was just approved is for high risk smoldering, meaning that your numbers are right there and it won't be long before you probably convert to full myeloma. So if your
Uh,
smoldering is not high risk, they're still watching and going to check your labs every so often.
Yeah. I see the participant put in the box there. Yeah, that's exactly what she said. Yeah. Yes.
Yeah, I had to clarify. I know I need to make sure I put it in the right context.
So thank
But
you.
I'm excited though that they're still deciding not to just sit and wait because before it didn't matter what your stage, you still had to wait
And
until you got myeloma to get any kind of treatment.
yeah. So this is groundbreaking. I mean, this is a big deal in the smoldering myeloma community. So just know that if you are smoldering, there are options available to you. It's not just let's sit and watch and wait there. Um, and just be prepared to have those conversations. Take this information that you learned today, be able to take that back to your doctors and have that conversation about, is it time to start treatment and things of that nature there. Okay.
Miss Madonna.
Is it where that we're out in treatment? Okay. Yeah. So Kim,
She,
you want
she,
to touch bases on that? I know you.
is your question, Miss Madonna, that everybody so far on this call that is smoldering is black? Is that your question? Yeah, no, it's not unusual because myeloma is more frequent in black people, usually black men. So there's a disparity between the diagnosis of myeloma in, let's just say, Caucasians and black people. Those are the two races we talk about most of the time. But even if you look at Asians and Pacific Islanders and Native Americans, their myeloma numbers are creeping up to be higher as well. So Native African Americans or Black people are higher, diagnosed more often. We get it more often. So it is not uncommon to unusual for me that everybody so far on here has said they're smoldering, has said they're black. They're still, they've done research on trying to figure out why we get myeloma more often than others. Oh no, not on this is not only for black people, Mr. or Mrs. Kamens or Kamens. Not at all. That's just happened to be how this audience played out right here, I believe. Because this person said they're not black, Valerie.
Oh no, that's okay. I mean, this is
Yeah.
just community, the Black myeloma health community. We try to focus on those things that affect us at different rates, but anyone is welcome here. So don't feel
Yes.
no, you're more than welcome here, and we're glad to have your input.
Yeah.
Yeah,
Yeah, we need some variety
exactly,
because, you can't cookie cutter this thing.
exactly,
So,
exactly.
Mr. or Mrs. Kamens or Kamens, do you have another question?
Mhm.
Okay.
Oops.
Oh, Mary said, oh, okay.
Okay,
She's
awesome.
talking to Mr. or Mrs. Kamens.
Sorry, I didn't um unmute. I was sitting there.
Oh, okay.
No, I don't
Hi.
have any. I don't have any other questions at this point because well, like I said, I just feel like a ticking time bomb because I have smoldering. I have some what do you call it? Symptoms, although not the symptoms they consider symptoms, the crab symptoms. Like I had a blood clot 2 years ago. Little things that happened to me that are not normal, but they consider me not low risk and not high risk. I'm sort of like in the
Standard.
middle. So
They
I'm
call
stuck
that
in the middle.
standard risk. Yeah.
I'm
Okay.
stuck in the middle.
Yeah. Okay.
So,
Just make sure you're comfortable with what you are being told. And if you're not, seek out information so that
yeah,
you are advocating for yourself. Because
I'm
I
all,
always tell people, I may have been to nursing school, but you know your body better than I do.
yeah,
So you listen to you, and if stuff is not right and you don't feel you're getting what you need, please talk to somebody or go somewhere and try to get the information. I'll say that to anybody.
yeah. I
Absolutely.
have tried. I went to another institution and they gave me the same advice. So
Okay, so
I'm
then,
sticking with it right now. I mean,
yes,
supposedly two good places, Memorial Sloan and NYU. So,
yes, ma'am. The two of the best. So
so there's nothing, I mean,
yeah,
it's
just
going to
just
happen at some point, and then I'll have to decide because my whole family's in Florida. So I might have to
oh
move there because I won't be able to take care of myself. I mean, I read enough horror stories about how, what happens to you.
yeah,
So,
you definitely could need a caregiver if it's all
yes.
possible.
Yeah.
You definitely need a caregiver, and that's for any health challenge.
Yeah.
Depending if you need treatment, you need somebody with you if you can.
Yeah.
Absolutely. Absolutely. Excellent information and dialogue. Thank you. Thank you. Thank you. Oh, we got a couple more hands. Okay, we'll make these the last two. So Mary and then Brenda.
Hi, I just wanted to speak to KT directly. I don't know how connected she is with HealthTree, but
Yes.
reading different things, I read a few things on smoldering that were very interesting about clinical trials and things like that. About diet, I just entered something else about diet, another seminar like this. So they have a lot of interesting information that, and again, I'm still in a state of overwhelm. So I know how you feel, KT. I don't know how far it is for you. And I really had to take a deep breath because I did feel like a ticking time bomb also, but it wasn't serving me. So I just had to calm down and let things take its course because I know getting hyped up for me would be too much. I'm just finding everything that I'm thankful for because I was able to retire and drop a lot of stress even before this diagnosis. So I'm just trying to take it one day at a time. And I'll be praying for you, KT.
Fight it with information right now.
Yeah, that's what I was going to
Fight
say.
it, fight it with information. Get all the information you can.
What you're
Miss
doing here, coming into webinars and participating and learning and asking questions, and that's what you just have to keep doing.
I
But
can't
yeah,
find the hand, but I'm on to let you know. But I am in a clinical trial of a diet. You had mentioned diet. Well, I'm either on a placebo because they don't tell you, or it's curcumin and some other call it supplement where they
Okay,
believe it changes your biome, and
okay.
they think that that's supposed to prevent you from going into full-blown myeloma.
Very, very interesting. Very
But
interesting.
I don't know because, like I said, I could be on the placebo too. They don't tell you.
Right, right,
So, but
right.
I figured it might help someone.
That's true.
yes.
This
Miss
is
Brenda White
well,
Phillips.
Mary and Katie said the word that I was going to bring up when I was diagnosed as smoldering. The hematologist did tell me to get on a good nutrition plan and to exercise. I just wanted to share that.
It's always a plus there.
Always.
And HealthTree did some work with Dr. Irvi Shaw when it comes to some studies on diet and how it affects the progression of MGUS and smoldering. So we'd be
That's
happy
who
to
it
get
is.
there. Yeah,
It's the
with
studies
Dr.
through her.
Irvi Shaw. Yeah.
Yeah.
Yeah, awesome, awesome. Well, thank you all for joining us. Kim, you got any closing words today get back to before we get back to our afternoon?
Yes, I just will. First of all, I want to thank you for the opportunity to come before you all. I've been doing this a long time. I've seen a lot. I've experienced a lot, and I like to share it. But my main thing is the same thing Miss Mary said when she said, do what you can do to get rid of stress on your life. Not to say you're not concerned, not to say that you shouldn't be cautious, but knowledge is power. And if there's somebody that said, you can't fight an enemy if you don't know who the enemy is. You can't strategize if you don't know who it is. And what does that mean? Meaning your enemy is myeloma and your enemy is going to be different than my myeloma. Get to know yours. That means the treatments for yours and all of these different things. Talk to your healthcare team. Please tell them everything. Let them decide what is relevant and what needs to be dealt with. And thirdly, lean on each other the way you're doing now because you will find a lot of information from patient to patient. A lot of information. I also speak to support groups. And so the amount of information that is shared is mind blowing. And just again, thank you again for the opportunity. And I'm just so glad to see where we are now in myeloma treatment because, again, as a young nurse, this is not what I was seeing.
Absolutely. Absolutely. Thanks for joining us. I always say just get connected. When you're connected with others, it makes it a lot easier. So, um,
Yes.
also, if you have not had a moment, visit the Black Myeloma Health website. There's tons of information there for you. And just as you leave the session today, we want to let you know about that survey. Take a couple of minutes, give us some feedback about your experience here. There are a few upcoming events I want to make you aware of as well. Monday, November 24th. This is a all community. This is a caregiver connection and conversation for all blood cancers. So it's, I think it's at 4 p.m. Eastern time there, as you see on your screen. On Saturday, this is just a couple of days away, we have the in-person event, the Connect Cures event. That's going to be in Spokane. So if you're in that area, there's still time to register and come out and participate in that event, get connected with other blood cancers. On December 17th, there's another webinar, community webinar coming up. And it's What's New in Myeloma, Insights from Dr. Ola Longren. The latest research from the ASH meetings. The ASH meetings are going to be taking place in a couple of weeks. So it's going to be kind of like a recap of that. We also have many other exciting virtual and in-person programs for myeloma, so stay tuned for those. The link to sign up to any of those events is going to be sent in the email, the follow-up email afterwards. And then I want to take a moment to thank our sponsors, GSK, Pfizer, Kite, Johnson & Johnson, and Amgen. And also thank you for making this such a strong community. Your support means so much. I've included my email address on this slide, so don't hesitate to reach out if you have any questions about HealthTree or any of the programs. I'm always here to help. So thank you. I appreciate each and every one of you. Kim, again, thank you for joining us. It's always a pleasure having you present and share your knowledge with us. So hopefully I will see you all on another webinar out there pretty soon. Enjoy the rest of your Thursday and have a good day.